So he was a 49-year-old gentleman. He came with the complaints of functional class 2 dyspnea on exertion since the last 2 weeks. On clinical examination, we found that there was a 4 by 6 grade, long, loud, continuous murmur at the left upper sternal border. On echo, we could see that there is a clover leaf shaped aneurysm, and on the long axis, we can see that the sinus has aneurysm has ruptured into the RVOT. So the diagnosis was clear. It was a ruptured sinus of Valsalva of the RCC into the RVOT. So the patient had a mild pH, mild AR, no VSD, good biventricular function, no mitral regurgitation. He was in sinus rhythm and was not in heart failure. So we went ahead with the cath study, and we saw that the RA pressures, the RV pressures, the PCWP and the pulmonary artery pressures were elevated. We found that the QP/QS, that is left to right shunt, was around 2.9. So we discussed with the patient and gave him an option of whether a surgical closure or a device closure will be suitable. Also on this angiogram, you can see that the patient has some more aneurysms which can be seen here, and one of the aneurysm has ruptured from the RCC into the RVOT, and this is an angulated rupture. So we spoke to the patient and also spoke to the cardiac surgery team, and then we went ahead with the plan of device closure of this defect. So in this, we took a Swan-Ganz catheter and we passed it into the aortic root, and from there you can see that the catheter is directly going into the RVOT without any trouble, which means that there is a torrential flow across the defect. Then we used a JR 3.5, and over that we passed a J-tipped 035 Teflon wire, and then we passed it into the pulmonary artery. Then this was exchanged, and a long sheath torque view of 8 French was used and then passed into the defect. From here we can see that we have taken 2 arterial line, and one arterial line we are passing the device, and from the other we are forwarding the pigtail catheter. So in this, the other view, we can see that the device is being forwarded into the defect. Here we can see that this is a Amplatzer vascular plug 2, in which the first lobe is coming out, while in the second view we can see that all the 3 lobes have come out. We took a check angio with this, but there was increased flow across this. So we thought that we'll again see, and then as we had measured the device previously, defect previously, it was 14 mm, so we chose a 16 device. But after the device placement and the large residual flow, we upsized the device to around 20 mm of Amplatzer vascular plug 2. So here we can see that the second device is being placed, and the first lobe is out in the first picture, and the second and the third lobe are out in the picture in the second one. So after taking a angio, we confirmed that the flow has reduced a lot, and so we decided to deploy the device, where we can see that the device is being deployed here. So on further angios, we saw that the device is stable and there was no much residual flow across the device. So the patient was followed up at 1 month, 3 month and 5 month. There was clinical improvement. The patient has improved to functional class 1. The device position was stable. There was no hemolysis, no RVOT obstruction, no ischemia in the RCA territory, and the patient was asymptomatic, and no evidence of any complications was noted at follow-up. So this was the first echo image that showed that there is a torrential flow across the RVOT from the ruptured sinus of Valsalva, while in this we can see that the flow is very minimal in this view. So we did an echo which showed that the LA diameter had come down a little bit, and but MR and AR were stable. The RVSP had come down from 44 to 28. This is the X-ray which shows that previously there was an cardiomegaly which had come down, and from this picture it is evident that it was a successful procedure. So we have some experience regarding RSOV device closure previously also. This was published in the Euro Intervention in 2010, and that time we had done around 7 cases. Now after this we have done 10 more cases, and this one was interesting because we had used a Amplatzer vascular plug rather than the usual PDA device we used. So the take home message is that RSOV is a rare condition, but it is 5 times more common in Asians. Although surgery is the gold standard treatment, percutaneous transcatheter closure has now become equally efficacious with fewer complications. Various devices like the Amplatzer duct occluder and the vascular plugs can be safely used without significant complications when done by experienced operators. And retrograde approach, that is from the arterial approach, can also be used if the anatomy does not favor the use of an antegrade approach.
What was the anatomical difficulty which made you choose
So
arterial?
the one thing was that it was a longer defect, and also it was angulated. So if we put a PDA device, that a PDA duct occluder, then it will cover up more area, and it might cause the obstruction to the RCA, and that might lead to ischemia in the RCA territory in the future. But here we had a space between the RCA, so we could place a vascular plug, but the occluder would have encroached upon the lumen or the ostium of the RCA territory, and also it was angulated. So that was one more reason that we did not go ahead with that thing.